Assalamu alaikum wa rahmatullah wa barakatuh, everyone. Um, First, I would like to thank you, everyone, for logging in today to our first of many, inshallah, scientific events which are coming throughout the year 2025. So we're starting today our webinar series 2025, which will be regular occurring for the Emirates Orthodontic Society. At the beginning, I would like to just take this moment to introduce myself. I am Dr. Mohammed Shalabi. I'm a consultant orthodontist, and I am the president of the Emirates Orthodontic Society. Along with my colleagues today, I would like to introduce my colleagues. We have Dr. Khalid Al-Amri, who is the vice president of the Emirates Orthodontic Society. We have Dr. Khalid Al-Katib, who is also here with us. He's the General Secretary. We have Dr. Muhammad Saleh, who is also the Scientific Committee Chair. And also, obviously, we have Dr. Abdul Hakim Al-Gharyani, who is our speaker today. And he is our chair of the Cultural Committee Chair and Public Relations. So this is actually the newly elected members of the Emirates Orthodontic Society. And we have been working quite extensively over the last 2 or 3 weeks or 4 weeks to rejuvenate the Orthodontic Society. Our goals this year will be to create a scientific agenda for the remaining of the year, which is actually coming into shape. We have the scientific agenda for 2025 will include regular webinars. We have some hands-on workshops being lined up. Probably we will have our first workshop in April, which will be announced quite soon. We have recently changed and modified our visual identity. We have a new logo. We have just launched our social media account, which is actually now available, the Emirates Orthodontic Society. We will be present on almost all social media accounts to publish our things. So we have also, back to the scientific agenda, we have the webinars coming. We have hands-on workshops. We are proposing another orthognathic surgery day, which will be a hands-on workshop. Also, it's coming soon. We have our residence day coming soon also. So this is actually a very good chance for us to join the Emirates Orthodontic Society. And obviously the cherry on the top, which is going to be our annual Congress, which is going to be held this year in October 2025. So save the date. This will be a big event, which will be held soon, which will be announced soon. We are actually currently in the finalizing the planning phase for our Congress, which will be held every year in October. So this is actually something that is going to happen, and inshallah, we will together we will make this society one of the greatest in the region. Also, currently we are actually working on multiple partnerships along with regional societies, as well as the WFO. We have actually a few things in the planning phase, where basically it will enable our members to access to scientific journals and scientific contents, as well as regular CMEs. So some of these events will be open for everybody. Some other events will be only restricted for Emirates Orthodontic Society members. So if you're not a member already, please join the society as soon as possible. And if you face any technical difficulties, and if you have any issues stopping you from joining the membership, the society, please let us know. If you have long-standing fees that you need to pay, also get in touch with us, and we will try to help as much as possible. So without further ado, I would just like to pass on the mic to Dr. Muhammad Saleh, who is our moderator for today, to introduce today's speaker. Thank you so much.
Thank you, Dr. Shalabi, for a nice speech. Welcome, everyone. Good evening. I would like to welcome you in our first online webinar of the Orthodontics Society. My name is Dr. Muhammad Saleh, and I'm honored to serve as the Scientific Committee Chairman. On behalf of the Emirates Orthodontic Society, I would like to extend a warm welcome to all participants. Without delay, let's start to introduce our speaker today, Dr. Abdul Hakim Al-Gharyani. Dr. Abdul Hakim Al-Gharyani completed his postgraduate training in orthodontics at the University of Colorado, USA in 2006, after earning his DMD from the University of Pittsburgh, USA in 2002. He also holds an MS in human genetics from the University of Pittsburgh and a BDS from Benghazi University. And he has also an MSD from the University of Colorado. Dr. Hakim is a certified diplomate in the American Board of Orthodontics, ABO. He served on the faculty at the University of Pittsburgh and more recently was assistant professor of orthodontics and clinic director of the European University of the College, Dubai. He is currently a visiting faculty at the University of Colorado, USA. Dr. Abdul Hakim is a quality-oriented clinician who treats all patients, age groups, and all types of malocclusions. He is passionate about providing his patients the best results in the manner studied for them. He is published in the prestigious Journal of Dental Research, as well as the American Journal of Orthodontics, and has been invited as a guest speaker to several international meetings. Dr. Abdul Hakim was the UAE ambassador of the American Association of Orthodontics and is currently serving on the board of Emirates Orthodontic Society as Cultural Committee Chairperson. He is licensed to practice orthodontics in the USA and UAE. Dr. Abdul Hakim enjoys family tracking and keeping abreast of all latest innovations in orthodontics. Dr. Abdul Hakim, stage is yours.
Thank you. Thank you very much. Bismillah. Thank you, Dr. Muhammad, for the introduction. Thank you, Dr. Muhammad, our president, with sharing all of these innovations with all the attendees. And thank you, all of you who have made time to be with us this evening. It's a great honor to serve you. And like Dr. Muhammad said, Dr. Muhammad Shalabi, that we are here to serve the orthodontic community, and we are open, we're all ears. Please give us suggestions and come join in. So tonight's presentation is Timing is Everything, a guide to pre-teen patient treatment so that we can treat them on time, every time. Sorry. Conflict of interest statement. I'm not receiving any funds for any of the content or for making this presentation whatsoever from an outside source. What I present is my work, and what I express are my opinions. So again, alhamdulillah, I live here in Dubai. It's a year-round sunshine city, so I enjoy the running. I'm blessed with a family. You can see here, this was taken a while ago. And also my passion is being an orthodontist and being a member of the Emirates Orthodontic Society. So what are we going to learn today? We're going to look at the controversies surrounding preteen orthodontic treatment. We're going to look at some of the common developmental anomalies. We're going to look at patient management, and then we're going to discuss strategies of how best we can treat our patients in these for this age group. We mentioned controversies. And this is why the American Association of Orthodontists a few years ago released this guideline that kind of tells patients and orthodontists that we really need to be seeing patients around the age of 7. And, why age of 7? Well, that's when we expect permanent teeth to erupt. And then it gives a few examples of different types of malocclusions to look out for. What's interesting is that in these pictures, these malocclusions didn't happen overnight. It took time for them to develop this way. Below the age of 7, obviously, that we have our pediatric dentist friends and colleagues, and they are more in line with treating patients prior to the eruption of the permanent teeth. So the terms early or phase 1 orthodontic treatment has often been used to describe treatment that is done in the transitional or primary dentition. Just minimize, yeah. Or the pre-adolescent orthodontic treatment. And basically, it was divided into 2 types, the preventive and the interceptive. And essentially, the preventive is anything that is done to save the teeth, and interceptive involved, moving teeth, correcting of minor malocclusions. And the rule was whenever orthodontics was done as early or phase 1, there had to be a subsequent stage later, or a comprehensive therapy later. And you can see here many books have been published using the title Early Orthodontic Treatment. And there's even the new early orthodontics and the early age orthodontic treatment. And in my view, as a resident, going through the residency, this was something that was eye-opening. I attended this in 2006. This is part of the Moya Symposium, which is a very high-class academic and scientific dental meeting. And in every year, they pick a subject. So in 2006, the title of the symposium was Early Orthodontic Treatment. Is the benefit worth the burden? And here you can see that, yes, need for early orthodontic treatment was recognized. However, there always was a way up. Do we treat now or do we treat later? And this is where the benefit versus the burden comes in. And I think this question is what leads to a lot of the controversies surrounding treating patients who are in the pre-adolescent phase. So in my view, I like to treat patients on time. I don't like to use the term early orthodontics, and you'll see why, because treatment should be done on time when it's needed. Just like you could have early orthodontics, is adult orthodontics deemed as late? And the answer is no. And that's why I do believe that using the term early is inaccurate for us. So we can all see here, and again, we don't have the polling started done, but you can definitely write a message in the chat if you'd like regarding the age of this patient. So you can see here we have 12 deciduous teeth. We have like maybe 1 coming out there. But essentially, how old do you think this patient is? And when we look at the OPG, again, you can see that all the deciduous teeth are there. And for those of you that have commented and said, yes, this patient is around 14, then you are right. But anything below is wrong. So you can see here that guessing or linking the patient's treatment time for orthodontic treatment based on their age is something that is not correct. Likewise here, we have a child with full adult dentition. How old do you think this child is? Well, you can clearly see that in the OPG, all the deciduous teeth are out. But again, if you looked carefully and you looked at the root development, you would guess that correctly this patient is actually not older than 9. Between 9 and 10. So once again, this notion that we have to wait until a certain chronologic age to get orthodontic treatment, and this is something on a monthly basis I'm seeing, that patients are coming in. having needed orthodontic treatment for some time, having been told many times previously that no, we have to wait, no, we have to wait. What are we waiting for your 12th birthday? Or the other thing that they're waiting for is the eruption of all the permanent teeth. So as you can see in the previous case, the boy got to 14 years old and his teeth hadn't erupted. And I think that if nothing was done, they probably won't erupt until he's in his 20s. And like this boy, this boy now on screen, he's 9 years old. And imagine having this overjet and being told you have to wait until you're 12 to get treatment. So that's why for me, it doesn't make sense. If there is a need now, then the treatment starts now. If there is no need, then obviously we have to delay. So I mean, moving on. So that's kind of where the crux of this presentation lies, in trying to deal with this kind of dilemma. When is the right timing for treating preteen patients? And why preteen? Except for the few, unlike the patient I showed you, by the age of 12 or 13, we expect the full dentition, full adult dentition to be in. So any patients that come in, there's no controversy surrounding their treatment, but the controversy is always surrounding the patients who are in this preteen category. So what I believe in and what I propose is a paradigm change, okay, where instead of using the terms early in phase 1, I think we should start focusing on using preteen and interceptive interchangeably. So rather than saying early, we could say preteen, and rather than saying phase 1, we would say interceptive treatment. And this interceptive or preteen treatment has to have a justification. So if there is a justification, we can intervene, regardless of whether the patient is 7 or 8 or 9 or 10. And even with the malocclusions, some malocclusions warrant a justification and some malocclusions may not. So the justifications are psychosocial, trauma disease control, and obviously functional development justifications. So psychosocial indications, it's already well documented. And here's an example of a study actually done by a group in Saudi Arabia, I believe. And they demonstrated that obviously a significant relationship between dentofacial features and the negative effects on quality of life. Additionally, this is another group from Scandinavia, once again showing that if you have a malocclusion as an adolescent or a child, you will have a negative self-perception, and this can lead to long-term negative problems. So obviously, why is this an issue? Well, the media is something that is a cause of this. And now with social media and imaging and self-awareness, you know, how people are portrayed in the media has a big effect on how in the population these patients exhibiting these traits can be viewed. So you'll never see the heroes in movies will always have a great smile, will always have straight teeth. And if a child is having an issue with this, then it should at least be checked out. If there is an underlying malocclusion that could be easily corrected, then so be it. But if it's not, then obviously this goes into psychological area. And within the US, we did a study back in 2003, and we found that in the state of Connecticut, if there is an underlying psychological impact because of the malocclusion, and you had the psychologist report, the state would pay for your orthodontic treatment. And it's the only place where I found that this was to be the fact. Could be that Connecticut has a rich orthodontic history. Who knows? But that's something that we really need to pay attention to. The second justification is trauma or disease control. And in this study, there's a big problem where they identified that patients with increased overjets had a higher tendency of trauma and breakage of these teeth. So and this is understandable. We have children as young as 7 having full-size adult teeth in their face. And if there's a narrow arch, then there's probably proclination. And we'll see later how we can manage these. So 2 weeks ago, I had a patient walk in, 13 years old. They just recently moved to Dubai from Europe. And the mom was telling us that for the past 2 years, the boy wanted to have orthodontic treatment, but their dentist in their home country was telling them he had to wait. And the mom also admitted that he was very happy that they're moving to Dubai because he hated the school he was in because of bullying. So these are things that we really need to pay attention to. And then you can see here, for example, huge excessive overjet, and then all of a sudden, the nose and the chin will not cushion. And when a child comes to you with this, you know that this is going to be a lifelong problem of getting good aesthetics on these teeth. And in the event that these teeth were not saved, then anyone working with implantology, dental implantologists, they will tell you the anterior zone is one of the most difficult areas to restore or to replace teeth because of high aesthetics, especially when the gingival margins are shown. So again, trauma and disease control. So if a child comes in and they're at high risk, we don't look at the age and it's permanent dentition or even deciduous. We really need to make sure that they're not an increased risk of damage due to trauma. This does not mean that every child with an increased overjet, you need to correct that, but only those with an increased risk. And we'll see later what that means. Additionally, you can see here, child perhaps a narrow maxilla, black eyes, they're not sleeping well, maybe they're restless, who knows? But these are things that you kind of look at when we start looking at patients nowadays. The other justification is anything that affects normal growth and development. And the most obvious one is thumb sucking. Okay, so the goal here is to really eliminate the habit first, and then try to correct the malocclusion. And obviously, this is a campaign that's run, I believe, every year by the AAO. Inshallah, we will be increasing our public awareness efforts in the UAE to bring these information to our local population. Again, another functional disturbance is functional shifts. And we know that if a child has a functional shift, that will have an effect on how the mandible grows and condylar growth more specifically. So you can see here, here's a child who bites on either right or left, but can never bite in proper occlusion. So she's constantly moving one side or the other. We can't leave this. When I see parents coming in, I tell them that this is like seeing a child or having a child with a stone in their shoe. So we really need to make sure that this is addressed. Additionally, now, more recently, there's been a big push looking at expansions and maxillary arch dimensions. And in this study published in the European Orthodontic Society Journal, it was found that, if you suspect that there isn't going to be enough room for the canines, they showed that patients that, they compared extractions, expansions, and no treatment. And they found that the group that had expansions actually had less need for more advanced orthodontic treatment. And what does that tell you? It tells you that perhaps our view as orthodontists that when we have a space shortage that we should extract, that might not be the real solution. Now, of course, here they were extracting deciduous teeth, but in permanent teeth, could we have done something to prevent this extraction? And we should be looking at this as well. Now, this is more controversial regarding pediatric sleep apnea. And I know now in the last 6 months, there's been a big move from the American Academy of Pediatric Dentistry and the American Association of Orthodontists. But I just wanted to pull out two references. This is going back to 2021. And of course, it mentions that it's a multidisciplinary thing. And obviously, as orthodontists, we need to do it. We would do expansion or mandibular advancement in the event it was found to be beneficial for the child. But what's kind of concerning is that some are trying to link the lack of treatment to causing these significant medical problems like behavioral issues, learning difficulties, and cardiovascular disease and retardation in growth. So obviously these are very bold statements that are being made, and this publication's on PubMed. So I think that this is very serious and it should really be looked at. And that's what the authors of this study, and this is one of the main authors, Dan Rinshuth, and he's obviously published the book on evidence-based orthodontics. So basically, when they did their review, they found that insufficient evidence to either confirm or deny. So what they're saying is, the jury's out. We don't know. Can it be or can't it be? So again, I think this is a great area for study and for research, and for those in the audience today who have the possibility to do this, we really need to spend more time and more effort to better understand what these conditions are, how we can treat these conditions. I can understand previously, in the past, perhaps the appliances we used or the mechanics we used were limited. But now I think that as technology advances, the big focus has been on appliance development. And I believe now we need to focus on diagnosis so we can better treat our patients. And again, these conditions should not be based on craniofacial morphology. So if you have a patient with a constricted maxilla, it does not necessarily mean that they have an airway problem. It has to be done in a multidisciplinary setting so that, ENT doctors, pediatric doctors, pediatric dentists, we really have to start looking at this from our respective perspective, so we can better make and treat our patients. Always, whenever we do this interceptive or preteen, if there's going to be a period where we expect to eliminate the justification, once again, if there's a reason, we go in, we eliminate the reason. This doesn't mean we put the appliances on and keep them on until all the dentition transitions. We're not really interested in things that are not justified. So quite evidently, you may find patients where treatment is justified because the child is getting bullied, and a similar malocclusion in a different child where the child is not having these problems, you may leave. So this is very important to really identify the patients that it can be used in. So the goals have to be clearly outlined. Usually there will be another phase of treatment, a comprehensive phase once all the dentition erupts, and a permanent dentition. And the goal here is not to burn out children. For those of you who are treating a lot of patients with mandibular prognatism from a very young age, that you're going to be stuck with this kid, or treating this kid, I should say, not stuck with them, but you're going to be treating them until they're into early adulthood, because you've got to make sure that they don't outgrow any correction you do. And even though you're going to be following them for that time, it doesn't mean that there's going to be appliances. So you just want to make sure that you correct the crossbite and make sure that they don't grow unfavorably and outgrow what you've done. And obviously you reach a point early on if the child comes to you at the age of 13 with an anterior crossbite of 8 millimeters, that the protraction face mask is not going to be doing you much good. So you limit treatment to just improve self-confidence, and then you deal with them later as an adult for surgery. So now, obviously, when we are dealing with children who are in the preteen phase for interceptive orthodontics, you're going to have to deal with the parents, and understanding what the parents want is key. So obviously, parents want the best for their child, and they're interested in results. So again, when you present your cases from the sense of justification, obviously, no parent is going to, accept that they're, the small, gap between their kids' front teeth is something that's going to have them go through school in an unhappy way. And if you can present this and say, yes, we can close this space, given that the child is really affected by it in a very short amount of time, then, they're going to be happy about that, and they'll be more accepting of the treatment. But what the parents don't want is obviously they don't want to do something now that can be done just as good later. And that's why the element of justifications has to come in. Of course, we can treat malocclusions later, but the goal is we want to make sure that if there's a justification, if the child is coming in with their teeth in a high risk position, is it worth it that the child is kind of, metaphorically playing Russian roulette every time they leave the house? Because all it takes is one bad fall and those teeth are on the ground. And I'm sure many of you have seen this. Plus, the parents don't want to pay more. They don't want to pay for 2 treatments if 1 treatment is enough. And of course, they don't want pain or inconvenience for their children. So hopefully at this pace, everything is kind of understandable. Now we'll transition and start looking at specific malocclusions. So and when I do the treatment planning, this is no secret. I'm a big fan of the Prophet text in his Acumen and Prophet diagnosis. He uses Venn diagrams and he divides everything up into dimensions. And this is taken from the Prophet textbook. And basically, we're going to look at arch perimeter problems that can affect the preteen children. So we can look at crowding, spacing, and eruption problems. So obviously crowding, there's a lack of space, or it could be interferences with eruption. And what are we looking at here? In mild crowding, we do space maintenance. So you can see here, and actually, the patient lost the D. You can see that there's some anterior spacing, but at least, abandoned loop space maintainer has been done. So I saw the patient having come in from their pediatric dentist with this in place, which is fine. Obviously, you can question the design, but it worked well enough. In my view, when I get patients looking like this, and there's still time to go, I'd probably put them in an Nance appliance. And then here again, this is a stainless steel crown and loop. So there's different modifications based on the patients, and this is work done by pediatric dentists. So hats off to them. This is a denture. Again, I've never done dentures, but as a child, I did fall and I lost a lot of teeth. And thankfully, alhamdulillah, my dad's a prosthodontist and he actually made me dentures as a space maintainer. I'm someone who benefited from that, even though it was kind of interceptive orthodontics done by a prosthodontist, but it served the purpose. Here in this case, you can see this is for a distal shoe. You can see in this case that we've got the red arrows are pointing to the 2.3, 2.4, and 2.5, and then you've got the yellow arrow pointing to the 6.5. So there's an ankylosed E, and it's preventing the eruption and it's causing this traffic jam. So we remove it, and we connect the band and loop off the 4. And yeah, once the tooth erupts enough, then we can change it to a Nance appliance. So these are just examples of interceptive orthodontics. Here's another space loss problem. Patient presented. You can see here over-retained. You can see the over-retained D. We've got the 4 trying to erupt. What we did was we just placed the lower lingual arch, and we placed the upper Nance, and then she disappeared for 16 months. And when she came back, this is how she looked. Okay, so you can see the Nance appliance was there, and she lost her teeth, and it's a pretty good result. Of course, I think that will she ever need orthodontic treatment? Of course, as she grows, I'm sure there's going to be some some rotations or developing, but primarily as it's not a significant malocclusion that would require very aggressive or very advanced treatment. Now, what about a premature loss of primary teeth and severe crowding? So here's a case. This is a 10-year-old presented, and you can see how we're missing a premolar on one side, and we're missing the canine on the right side. And so when I analyze these cases, it's like, what do I need to do to correct the anterior posterior? What do I need to do to correct the vertical and transverse in this case? and transverse, obviously, she has a crossbite. And then here, the anterior posterior, canines class 1, but I've got a molar in class 2, and that's because I have teeth that are impacted. So again, this child was 10 when she presented, full adult dentition, and she's being told to wait until she's 12. This case is not going to self-correct, and it's only going to make things more complicated. So, what did we do in such a case? Well, again, we expanded to correct the transverse. We used combined with the distalizer. So that's what we did to expand and distalize. We were fortunate in this case in that she did have a slightly concave facial profile, and then just put the brackets, and this is the finished case. So again, this is just as a concept. We finished her treatment at the age of 12, where some patients are being told to wait until the age of 12. And this is the message I'm trying to say. I'm sure for all the orthodontists in the audience, in your own rights, fantastic. But really, it's the concept. And perhaps it's not for you, but it's for the doctors, your colleagues, your referring GPs, your referring pediatric dentists. You really need to get this message out there for them to stop telling patients to wait until the age of 12, or for them to tell their patients, wait until you change all your teeth. Because if there's a justification, you really have to start treatment sooner. And then again, like I said, profile improved. Of course, if this patient presented with a different set of profile or a different profile arrangement, it would have been treated differently. And again, that's the topic for another day, where we look at how we look at patients and we analyze them in a way to come up with the best plan for them. Okay, and then this is just comparing. And I know it's the evening, so don't worry. There are no Ceph numbers and no small slides. So it's all big text and lots of pictures, I hope. Okay, thank you for being here. So now we're looking at spacing with like diastema. Once again, management of diastemas, unless they're causing a big issue, it's better to wait. And usually, oftentimes, we can wait, but I wouldn't recommend just closing the diastema for the sake of it being there. And I generally prefer to wait until towards the end of the orthodontic treatment to remove any frena or anything like that could be causing it. Why is that? It's because I don't want to have any black triangles. And now with lasers, it can be done very effectively. I've seen some who have advocated for removing frena for the space to close by itself. I would manage it as part of an orthodontic plan rather than an isolated procedure. You can see here, this is a patient who presents with a diastema, and she has a posterior crossbite. So again, spacing, but you need to expand. Here's another example of a patient with a diastema, and they have they only have one conical incisor. So again, this is an interesting case. How are you going to manage this? Well, if it's not bothering the child, then you leave it. Anything that would require restorative treatment generally would like to delay until the patient's a little older. Here's a patient with a gap in the middle, but you can see they have severe crowding. So in such cases, how it's you have to expand, and then obviously the diastema will get taken care of. So again, just because the patient has a diastema doesn't mean there's sufficient space. You really have to look carefully, of course, and I'm sure that's what all of you are doing. But what's interesting is that this patient obviously had crowding, and in the lower, she had like a supplement lateral. So she had 4 lower incisors. Sorry, she had 5 incisors, and obviously one had to be removed to allow the canine to erupt. So again, it's there's a lot to be seen in these growing kids, and not seeing them seeing them before the age of 12, or once all the permanent teeth have erupted, or you're wishful thinking to have all the permanent teeth erupt. is not really the way we should be practicing. Here's another patient, severe diastema due to proclination. And again, this patient, swears that they've never sucked their thumb and they don't have a thumb sucking habit. But that's okay. So again, these are diastemas presenting in different cases, in different ways. And this is the patient in the Ceph. And of course, it's not just diastema. Thankfully, she managed to survive until all the permanent teeth erupted. But again, she's a very high risk. If she was to ever fall, those teeth would have definitely been damaged. And then obviously missing permanent teeth. We get patients coming in with missing permanent teeth with, so we would look at the deciduous second molars. Would they be a good option to replace the permanent, in the event that there's a missing 5? So if we look here, for example, this actually is taken from an adult dentist, and she was actually told to remove that tooth. And you can see in the literature that no, the survivability of well-maintained deciduous teeth, especially these second molars, can be as good as, if not better than, having an implant. So it doesn't make sense for me. And then for these cases, what you need to do is you just build them up. And that's it. I didn't do the build up, of course, but that was the recommendation. So it doesn't make sense to take them out, but you just have to continuously review and make sure that you can build them up. This, on the other hand, is slightly more challenging because we have a patient with how many missing teeth? You can see that we've got the missing laterals and we've got missing premolars in the upper. So this patient will definitely require restorative replacement, because you cannot have, central canine premolar molar. Okay, you can do canine substitution. You can bring in the premolars for canines, or you can open the space for laterals. So the question here is, do you replace the laterals, or do you replace the second premolars in the upper? And that's where, even though the plan will not be done at this age, you have to talk to your prosthodontist friends and implantology friends to kind of, in preparation, if the child would like to improve her smile, do you open spaces and place Maryland bridges, or do you close spaces, do some reshaping, and hold the space in the back? So again, these cases present big challenges from an aesthetic standpoint, and understanding that you'll be waiting a very long time for the permanent teeth to completely erupt. And that's why I encourage a more thorough evaluation of the preteen age group to spot these things, because if they are there and they're missed, it would have a big impact on the child growing up. And you can see here, these canines could quite well be reshaped to look like laterals, at least on one side, the right side, but the left side is not. So it's always best to do symmetry. And then I believe in this case, it was, in talking to mom, etc., and dad, I think they went for replacing the putting implants in the lateral position. So space was opened up, and deciduous and Maryland bridges were done. Then we look at eruption problems. Again, this is all with arch perimeter. So I know we want to really zip through and get on with it. So again, this is how old is our patient? We already know, but this is for delayed eruption and over-retained deciduous teeth. So you can see, I saw this patient back in 2015. And then what we did was I made space maintainers in the form of like a modified quad helix and the lower lingual arch, and we started extracting quadrant by quadrant. And you'll see in the X-ray, this was a year later. So so he was clearing out quadrants every 2 to 3 weeks. He'd clear out a quadrant, and a year later he still had spaces. But you can see this is the original X-ray, where had these teeth been spotted and removed earlier, I think that his teeth would have erupted sooner, because those deciduous teeth were actually in the way. And we all know that the teeth erupt when the roots are 1/2 to 2/3 formed. So again, this whole notion of wait until you're 12 or wait until all the permanent teeth erupt is something that I would not recommend. And you can even see the tooth 3 was kind of ectopically erupting and kind of came out mesial to the deciduous canine because these teeth weren't exfoliating. The way I would manage it now, as I've seen some more cases similar to this, is I would start with removing the C's and D's, and then keeping the E's. At least the child will have the second, the deciduous molar and the first molar to chew. And then once the 3 and 4s have erupted, then I can consider removing the E's if they haven't exfoliated by then. And you can see this is the X-ray a year later. We're holding the space and we're allowing teeth to erupt. And then once all the teeth erupted, then he's in fixed appliances or he's in his comprehensive phase of treatment. This is again going back to our 9-year-old with all the adult dentition. How did I manage this? Well, you can see by the day, it was just before COVID. So we made a removable appliance for him. He got the appliance and he got the whole series. And then he appeared more than a year later, and this is how he looked like. So this is all self-care at home, changing and just changing the appliances and making sure that things lined up. So yeah, we have a little recession. When my periodontist friend looked at it, he's actually said, yeah, it's all in the enamel. There's no cementum, so there's no real recession, but we just have to be careful and make sure that we don't push this tooth and lose that small band of attached gingiva. Once again, he's 9, he's now 10 years old, and he's in a much better position, I believe, and it's still ongoing. So it's really a comprehensive treatment phase at this age. Here's another child, again, similar to the one I showed earlier, where, we're missing a whole tooth on the upper right side. We take the CBCT and we find that the teeth are there. So this is an ankylosed E that needs to be removed. And again, if the child is closer to having all the permanent teeth out, then it's a comprehensive phase. If not, then it's a interceptive phase. And you can see here we've got the 3 and the 4, and then we can see here there's a big traffic jam going on as well. So these are things that that need to be attention need to be paid. We need to pay attention to these. Where if dental development and skeletal development are not in sync, perhaps here we could look at possibly removing a molar even to allow the 7 to erupt. The patient's only 9, and or you can go in and try to remove the 8 perhaps, but still these cases are very challenging, and in another time, in another setting, we'll go through like category by category. Like Dr. Muhammad said, we really want to engage the community, and we want to bring back to life orthodontics, because we all love and are passionate about this, and it's great to share ideas and to create study clubs, and we can look more closely at how we manage these cases. Here's a very interesting case, again, with supernumerary teeth. So you can see in this patient, in the midline, this is a supernumerary tooth. This is what the OPG would show, but obviously we took a CBCT. And when you look at the CBCT, this is going back to 2011. You can see the yellow arrows pointing to the impacted central, the red arrows pointing to the erupted supernumerary tooth. But when you look at the CBCT, you see that there's actually a second mesiodens, so like double mesiodens. So again, it's very important to document, to diagnose your cases, and to identify. Again, just very briefly, this patient, I was the orthodontist. His pediatric dentist was Dr. Manal Halabi, actually, and his surgeon was Dr. Yasser Khabbaz. So, again, collaborating with doctors and specialists in different clinics is something I encourage. And, no man is an island, or no woman is an island. So, you really need, if you want to provide the best for your patients, you really have to work with the best. And I'm sure your colleagues in your clinics are the best. So if you don't have a specialty in your clinic, then you probably need to work with someone outside your clinic to make sure that you give your patients the best. So you can see here we did expansion prior to surgery. This is a risk management issue. We bonded the teeth that we need to keep because of the numbers to make sure that the right tooth is removed, because that would be a disaster if the wrong tooth was done. So I'm just showing you this slide for that. And then, of course, immediately post-surgery, we placed like a Nance appliance, but it was modified to have a Pontic tooth, and we used that as anchorage to move the teeth around. And thankfully, 2.5 years later, this is how the case finished. But just to tell you that supernumerary teeth can exist. You can't wait until the patient's 12. A lot of these kids with these problems present earlier, and this idea of wait till 12, do your or until all the teeth are up is not a good option. And then what's interesting is that at the time when we debonded, we took the final X-ray and we found he had 5 more supernumerary teeth. So we kept an eye on them, and then I believe about 3 years later they were all removed. But he still kept his retainers and everything was fine. Okay, and then you have ectopic eruption. This is a problem here. I'm seeing this quite a lot now, where the sixes are erupting mesial underneath the E's. Please don't extract the E's, because if you do, you're definitely going to need to regain space. If that was the only thing you had to do, you just need to explain it to the parents. Another option, if you can get access, would be to just trim or place a separator, and maybe even unlock the contact carefully, making sure that you have the crest of contour. So if you remove that should help the tooth get lodged and move through. Okay, so we'll hopefully we'll have time for questions at the end of this. Then we are going to look at AP problems. Dental protrusion, like I mentioned, these are children who are at an increased risk of damage due to trauma. A very simple test to do this, and it was taught to me by one of my instructors as a resident, just to place the palm on the chin and the nose and push. And if you can feel the teeth on your hand, those teeth are in a high risk position. And the goal would be, not to correct them to class 1 malocclusion or even reduce the overjet to ideal. You just want to get them out of harm's way, so that if the child puts his palm on the chin and nose, or if you put your palm on the child's chin and nose, the teeth won't touch. Okay, that would be the goal. Just bring them back so that the chin and the nose can cushion the teeth. Very quick in and out. Here's another child, again, midline perfectly on, minor rotations. Do we really need to correct this crossbite at this stage? It can be left. In her case, yes, because she was actually a child actor and she wanted to make sure that, she wanted to get more roles. So at 2013, this was corrected with a simple removable appliance to kind of just push those laterals out and keep them out. And that's how it was. So really, the rest just, and then, we were waiting for the E to erupt in the lower, and they're like, yeah, we're fine, but basically she just wanted to be able to smile without the crossbite. Here's a 7-year-old who comes in with anterior crossbite, a traction face mask, and head and expander. Within 5 months that we jump the bite and we wait. We just, you see, if the mandible is going to outgrow the maxilla and it's genetically predetermined, you're not going to change that. But what we want to do in such cases is remove that stone in the shoe to make sure that the crossbite is not being exacerbated by the crossbite. Okay, now we're going to look at some vertical problems. And again, we just to give you an idea, open bites and deep bites. The deep bite we're going to leave till the end. So now we're just going to look at one open bite case. You can see here habits, possibly tongue thrust, but there's an anterior open bite. So we just placed an appliance like a tongue crib and just let it work by itself. And you can see, yeah, with the tongue out of there, it's good. This was treated in 2012. A lot of times nowadays, we are looking at kind of myofunctional therapy, tongue training, and the like, because, you know, from here, he went into fixed appliances and we managed to correct that. If we weren't, then the chances of relapse could be there if he continued with his tongue habit. Now the transverse posterior crossbites, functional shifts, and narrow arches. We're just going to leave narrow arch till the end as well with the deep bite as a combined case. So with the transverse posterior crossbite functional shifts, I showed you this case, you know, where the child was unable to chew. So what did we do to correct it? We just placed an expander and we expanded. So you can see the teeth are not very well aligned, but we got them out of the functional shift. And then we take a pause, you know, we give them a removable retainer and we wait. The child is still 8 years old, you know, the lower canines aren't even due to be erupted yet. So it doesn't make sense. Like for me, it's not you do one treatment, then it's finished. For me, interceptive, if it's required, is done. If it started, you have to follow up until all the teeth erupt. So maybe the active phase of treatment is a few months, but you constantly keep monitoring so that they don't fall back into the old ways or the ways that justified. And as teeth erupt, you want to make sure that nothing unfavorable presents itself. So again, it's interceptive, but it's kind of, you know, it's done for the child's benefit. You want to keep the active phase of treatment as short as possible, but definitely you'll be observing until they're ready for that phase 2. Okay, so now, again, this is the last case for the evening. This is a case where there's a transverse and vertical, where there's a narrow arch. And narrow arch for me is where we've got narrow arches, but there's no crossbite. So you know, like, you know, because often, again, Gianelli wrote a paper about is there a justification for expansion in the absence of crossbite? Well, if both arches are narrow, then you need to expand. But anyway, he's no longer with us, regretfully, so he can't defend his argument. But like I said, let's look at this case closely. So here's a child. So you can see very narrow arches, but you know, you can see that the molars are not in crossbite and severe crowding. So this is what actually one of my resident cases, and I'm happy to be sharing it with you. So you can see what we did was this. So this is the child. Okay, this is very, you know, increased overjet, very unhappy, class 2, narrow, you name it, it's there. And also there is a deep impinging overbite. Okay, so again, how, you know, just to kind of show you how I plan, I've got a vertical problem, I've got an anterior posterior problem, I've got an arch perimeter problem, I've got a transverse problem. So how am I going to correct these? Again, I did this with Chuck Alexander, so cervical pull headgear. AP, again, we're going to correct it with the headgear. Arch perimeter, expander, expander, and that's classic Alexander mechanics. So that's this expander. That's what we did, and we connected that to a cervical pull headgear. And then as the spacers aligned, as the spacers aligned, we went ahead and we bonded some brackets and lined things up. So you can see here, this is the end of the interceptive orthodontics. Is it a completed case? Absolutely not. And then as part of the retention protocol, would give them like a removable plate with anterior bite plate. Okay, and that's it. And then, you know, we would monitor. Once all the teeth erupted, then we'd go ahead and we'd get started with phase 2. Okay, or with the comprehensive treatment. Okay, very good. You can see here, and you can see now she's ready to get started. All right, so with that, again, just coming to the conclusion, you know, yes, as orthodontists, we kind of assume the responsibility from about the age of 6, but it's not a start-stop. I think that if our pediatric dentists, friends, and GPs who are treating children are more aware of these conditions. Even if I'm not, I'd rather treat patients beyond the age of 7. At least you can coordinate the treatment so that whatever is done prior to you receiving the patient is going to be more beneficial for the patient. Again, I'm a member of the AAO and of course the Emirates Orthodontic Society. And for those of you that are not members of the Emirates Orthodontic Society, we look forward to you joining. And so just the take-home messages are that in interceptive orthodontics, the goals must be clearly outlined and understood. Usually there's a second stage, which will be needed, the comprehensive, and you have to set specific endpoints. So you have to target patients and say, you have to list the justifications for the parents that are clearly visible, and then the parents can, they'll know, okay, yeah, the V-bite is gone, or the diastema is gone, or yeah, my son is, or my daughter's smiling more. These are things that you have to work for. And of course, always look for the justifications. Don't focus on the patient. Is there a psychosocial issue? Don't look at malocclusions, angle classification. Is there a developmental or functional problem? Is there a disease or trauma control issue? These are the things we should look at. And I know that I saw this in the US, and I see this, I've heard this here as well. For patients with insurances, there are those that would say, no, I'd rather wait, because if we start them early, then they might not get approved later on. I think that's a misnomer, because if the child has a 9mm overjet and all you needed to do is bring it back to 6 is still approved by insurance, but it might put the teeth out of harm's way. So if you view things in this way, then this you'd be doing a big service for the patient, and you're not gonna get them discriminated against moving on down the line. And I think bringing awareness and using this as outreach for us, in our efforts as the Emirates Orthodontic Society, we want to increase awareness and hopefully get insurance companies online or on board to make sure that no one's treatment is delayed when it is justified. And with that, I'd like to thank you all very much for your attendance. And I hand back now to Dr. Muhammad Salah for any questions.
Dr. Abdul Hakim, many thanks for the amazing lecture. This webinar marks as a significant milestone for our society, as it is our first scientific activity. And we are really excited to bring together orthodontic professionals, academics, and students to share knowledge, ideas, and the best practices. This is just the beginning of our activities, and we are excited to line up with the events, conferences, and workshops that we plan for the coming year. I invite all the participants to actively participate in our webinars and the future events. The engagement by feedback, suggestions are really important for shaping and lining up our direction in this society. Let us all work together to advance the field of orthodontics in the United Arab Emirates. So I would like to open now the Q&A. If anyone has any question for the Dr. Abdul Hakim.
Anything in the chat, maybe?
I have a question, Dr. Abdul Hakim.
تفضل.
Now, in the literature, there has been actually a number of citations that actually with roots not fully developed, trying to move these roots might actually affect their overall dental development in the future. So basically, you will end up with slightly shorter roots if you start to move them early. Now, personally, I have a lot of patients who are actually preteen, and even actually 6, 7, 8-year-olds, and we do a lot of expansion, some 2x4 appliances and some of that. I haven't seen actually a significant uh, effect on the overall root length overall. So do you have any uh, comment about moving the teeth uh, when the roots are like, let's say, 2/3 developed?
Perfect. Again, shukran, Dr. Muhammad. Thank you for the question. Teeth, when they erupt, they're half to 2/3 formed. When they're fully emerged, they will be well beyond the 2/3. So they'll be near completion. The general rule is we prefer not to be treating children who are young. Okay, so ideally we wish we had no need for interceptive orthodontics. So my view is, which is better, either having, in the event, again, I've not noticed it either, but it's mentioned in the literature. We respect the literature. But in the
Exactly,
event
it's
that there
mentioned in
was,
the literature,
yeah,
but actually it's not
yeah,
always, you
yeah,
don't always see it. Yeah, I have been looking at this. It's not actually, I didn't see it actually as a hurdle to this.
yeah, and that's why, which is more significant. Telling the child who's 8 years old, no, well, we still have your incisors another year at least until the root is completely formed, or do we start treatment? This is one. Secondly, obviously, choose your mechanics wisely. Don't use aggressive mechanics. Use slower mechanics. Use very light forces, because really your goal is to eliminate the justification, not correct the malocclusion per se. So if the child is bothered psychosocially, you want to correct that. If there is a functional or developmental problem, you want to deal with that. If there's a risk to disease control, risk to trauma, you want to deal with that either. So the paradigm changes. We're not correcting class 1 to class 2 to class 1, or class 3 to class 1. We're just dealing with that thing that made us start. The rest we deal at a later age. And I think that this paradigm changes how I treat the patients. So it'll be very short active treatment times and a long observation time, which is fine. They keep coming back. Yeah.
Thank you, doctor. Thank you.
Thank you.
May I ask 2 questions?
You can ask all you want. Yes.
So the first question will be about the upper laterals. If we are planning to bracket these laterals, I have always this concern about the contact between these lateral roots and the canines inside the bone. Do you have any recommendations to avoid that?
Yeah, the lateral roots, you see, when you place your if you're going to be placing brackets on erupting, like during this phase, you never place the lateral brackets so that you change the root position. So you would place your brackets on the centrals, and then they will be in line with the laterals. So the laterals, the crown might be off. You're not there to upright the crown or to correct the crown. You just hold it. So generally you keep the mesial tip of the lateral roots during this interceptive treatment. You will not correct the root position of the laterals. That is not advised or recommended. So if you need to do a 2x4, for example, you want to make sure that the centrals are positioned correctly, but the laterals are in line with the centrals. You don't want to change the tip. Because otherwise you will send the lateral roots into those canines and you will create resorption, serious resorption. And this is the same strategy to be employed even in comprehensive orthodontic treatment, where you've got canines that are very in a dangerous position next to the roots. They're erupting, they're delayed. So in our clinic, we have what we call the blue box brackets. So these are all the leftover brackets from the broken kits. And because in leveling and aligning, all you're using is round wires. So it doesn't matter which bracket you put on the lateral. Even if the torque is wrong, it's still a round wire, so it won't have any kind of issue. So we just say, right, we're going to put a blue box bracket on the laterals, just make them in line with the centrals. Once we have the canines in a safer place after the exposure, etc., then we get the real lateral bracket and we put that on the tooth as a repositioning.
Very nice. We have one question from Dr. Mariam. She's asking, on the last case that you have presented, why you did not correct the deep bite?
Perfect. This I treated as a resident. She was treated, this was the interceptive phase. So the interceptive, what was our justification? We want to line up the teeth and we want to get the teeth from impinging on the palate. Not deep bite correction. Remember, interceptive for me is elimination of the justification. So even if there's residual crowding or there's a residual deep bite or there's even residual overjet, the goal is not to correct the malocclusion. The goal is to eliminate the justification. And that's why you go in, you treat it, you leave, like you leave it, and then you observe. So it's not a finished case. It's still a work in progress. And that's why, when I hear people saying, oh, we do interceptive orthodontics, and I see this quite a lot actually. Oh, we do it so that we don't need orthodontics later. No, that's not true, because you never know until all the teeth erupt. So if we need to do interceptive orthodontics during the mixed dentition, then we want to finish as quickly as possible by eliminating the justification. But great question.
Thank you. So I will move to my second question about the traumatized upper centrals. If you have an ankylosed upper central and a preteen patient, what you will do?
Okay. If obviously what is the challenge or the problem that this causes is that this tooth will not move. It's going to behave like an implant. So in this case, you will have an aesthetic problem and you will have a functional problem. Based on those, you will plan your treatment. So if that tooth is ankylosed, let's say, but it's not really why you're going in for the treatment. If the tooth is broken and ankylosed, you could just do a restoration on it, and just keep it there. So it really depends on the specific case, but that's and sometimes you've got to remember that if a child was to fall on a table edge, even if their teeth were in a perfect position, they will still be traumatized. So we're not preventing the occurrence of trauma in children. We are reducing the risk of damage due to trauma in patients with increased overjet. So if a child with increased overjet was to fall, we recently had one where it was extracted. We actually took out a central because it was so badly damaged. They tried root canal treating it, kept multiple infections. So yeah, he's using an appliance and he's got a pontic tooth. And eventually he will have an implant in that position, but it could not be saved. So that's kind of a simple answer to you, but really we have to look at it case by case. But if the tooth has to go, then it has to go.
Nice.
Allah. Yeah.
Okay, any further questions for Dr. Abdul Hakim? Okay, I think that's it. No further questions. Many thanks again for this amazing lecture, Dr. Abdul Hakim.
شكرا. الشرف لنا. بارك الله فيكم. Wish you all the best. شكرا. Thank you.
Inshallah. So I think that's it. This is for tonight, and we are very happy for our audience. We would like to thank you for being here tonight, and we hope to see you again, inshallah, in our next scientific activity. Inshallah, we will announce about that very soon. Please follow us on social media platforms, and we will see you, inshallah. Assalamu alaikum.